Good morning, everyone, and thanks for the introduction, Pat. A. Thank you.
Oh.
A. Anyway, it's my pleasure to show some data with you that comes from a very well-known study, PrEP study, conducted by Connie Callum and Jared Beaton, that started in 2008. And the work I'm going to present today is a sub-study looking at the effect of PrEP on the sort of seroconversion pattern of HIV, with a specific question about whether this will have an impact on our ability to detect early infection in the era of PrEP. And Eric Ramos did, and Joan did the lab work, and Deborah Donnell, who I thought I saw, there you are, did the analysis for this study. So, why 2008? Well, the only thing you'll remember from this lecture is what I'm going to say in the next few minutes. In 2008, January 11th, 2008, 2008 is when this big study started, Bob Dole was around and was quite famous for his Viagra commercials. And at the Super Bowl that year, Bob came on the screen, and he was walking on a beach with his dog, and there were a couple of girls in the background, and he indicated that he always talked difficult subjects with us, but was always honest. But he found a product that gave him stamina, virility, and made him feel really good. And of course, then he said, I want to introduce you to my little blue friend. Well, everyone was expecting him to pull up Viagra, but he pulled up a can of Pepsi. That was then. Now, of course, our little blue friend is Truvada, and I would love to see that same commercial done with him pulling up Truvada. After he took the Pepsi, he did a backflip, introduced himself to the two girls, and obviously hit on them. I'd love to see that now in different contexts, right? So anyway, so we're here to talk about the little blue pill today, and how it's influencing a part of our life. And I'm going to share with you this data that the team has generated. So by way of background, there are a number of randomized clinical trials of tenofovir. We just say tenofovir FTC. It's a combination of emtricitabine and tenofovir. That's the blue pill, Truvada. And it's been used as pre-exposure prophylaxis in many of these trials. And Jared Beaton just came in the room. He's one of the co-PIs of the bigger study. And they've shown really reduced risk for HIV transmission across these studies, anywhere from around 50% to 90%. And clearly the success of PrEP is dependent on adherence to the use of the drug. So primate models show us, or tell us, that PrEP reduces viral load in the primates with this SHIV viral construct, but it has little impact on the timing of seroconversion, the production of neutralizing antibodies, and has effect on the maturation of antibodies as measured by avidity. But otherwise, that's what we know. And it's clearly biologically plausible that PrEP use could affect the appearance and concentration of the various biomarkers that we use to identify acute infection and stage acute infection, which occurs over a sort of a programmed series of events involving the measurement of HIV RNA in the plasma, P24 antigen, the development of antibodies, and then an antibody profile that's measured and over time. And this all generally tends to occur within about a 3-month period of time. And that's called phoebic staging. And that was the interest of our study, was to specifically look in this large study, placebo-controlled study, whether or not the phoebic staging was influenced by the use of PrEP. So PrEP could also result in the delay or attenuation of these markers, and could even, in theory, result in skipping some of them. So it's quite an important issue. Now, these, as I mentioned, these would have, if PrEP influenced the phoebic staging, it could have an effect on the routine laboratory diagnosis of acute early infection. So the majority of HIV infections on PrEP occur when participants are not adherent to PrEP, as I've indicated. With perfect adherence, the protection rate's around 90%, and then it drops with non-adherence. In the time between HIV infection and laboratory detection, for those of you in the PrEP area, it's generally about a 3-month interval. We see patients on a regular basis. And during that time, if they're on suboptimal levels of PrEP and become infected, clearly the virus is going to be exposed to these suboptimal levels. But this is what we expect could happen in the clinical setting. And as I mentioned, little is known about the specifics of the immunologic progression on PrEP, and that was the purpose for doing this sub-study of the larger PrEP protocol. So this study enrolled just under 5,000 patients. They were participants. They were discordant couples in Kenya and Uganda. It started in 2008 when Bob Dole presented us with that Super Bowl commercial, and went up to 2010. What happened then, but just after, first say, they were randomized 1:1 to placebo, so that was very important, so we could look at the natural history of seroconversion. Then tenofovir alone or tenofovir in combination with FTC. And the study was stopped early in 2013 because the effect was evident, and so the placebo group was re-randomized to either monotherapy with TDF or the dual therapy with TDF and FTC, and the study carried on. Altogether, when the study was over, there were 138 seroconversions that were observed, and these are the data that we'll use for the analysis. So the specific aims of the study, there were 3 of them, based on the hypothesis that PrEP will delay the expected biomarker-defined phoebic stages of acute, recent, and early infection in this clinical trial. And the other thing is that the phoebic staging that is in the literature was done on clade B. This is all clade C in Uganda and Kenya. So we wanted to do with 3 specific aims and assess whether the time to progress through the phoebic stages was affected by PrEP, to assess whether the virologic or antibody responses were affected by PrEP, and assess an association of PrEP with a delay in detection of seroconversion by the sites versus what we did in the central lab. Now, I'll show you that scheme of sample acquisition because it's important in the modeling that Deborah did to come up with the estimates of any delay in reaching the particular phoebic stages. So this is a diagram. I think there's a pointer here. Okay, so on the abscissa we have time in days up to about 100 days is 3 months. And here we have the plasma RNA levels and the classic curve of viremia. There's an eclipse period between acquisition of infection in a submucosal site and then spread to the regional lymph nodes and then into the blood. And that's generally about 10 days, median time about 10 days or so. In about 5% of individuals take longer than that. The first stage is just RNA, is all that's detected in the blood. That's called phoebic 1, lasts about 5 days or so. Then we detect antigen in the blood and RNA, phoebic stage 2, still no antibody. And stage 3 is characterized by the first detection of IgM-IgG antibody that's specific for HIV-1. Stage 4, we start, the original classification was based on Western blot, which we did in this study as well. We get indeterminate serologic Western blot confirmation for stage 4, stage 5. There's seroconversion in Western blot, but no P31. P31 is the antibody against the integrase. And there's a long period, and then generally at the end of the seroconversion is considered complete when P31 antibody is present. So this sort of defines RNA, P24, the presence of HIV-specific antibody, and then a Western blot seroconversion pattern that takes up to 100 days. And that's what we call ephebic staging, so 1 through 6. And that's specifically what we looked at in this study. I put this into a table showing the stage from 1 through 6. We looked at RNA only for stage 1 because everyone was assumed to have RNA after that. We looked for the first detection of antigen or antibody reactivity, which is stage 2. We used 2 assay formats, Architect and the Biorad. Architect is a chemiluminescent assay with a very large dynamic range that allows us actually to quantify the response in the assay to the antibody. The Biorad combo is an EIA. It's got a very narrow dynamic range of basically plateaus at about 12 or so. We used multi-spot at the time we did the study to differentiate to identify and differentiate the infection as HIV-1 and pick up antibody, IgM and IgG, but we didn't distinguish the two. And then the Western blot was used at stage 4 for indeterminate, stage 5 a full seroconversion pattern, but no P31, and then P31 appears for stage 6. So we're interested in the timing from the first seronegative through to the first reactive tests in this scheme from 1 to 6 staging. That's sort of the gist of it. And here's why the sampling is important. Participants were enrolled at time 0, and then at monthly intervals the site did rapid testing for HIV. They did 2 rapid tests. If either one or both were reactive, they then went on and did a 3rd or 4th generation EIA. And that was done on a monthly basis, but specimens were only stored at time 0, first month, 3rd month, 6th month, 9th month, and every 3 months thereafter. So you can see a couple of issues concerning here it indicates a site detected it, for example, here at month 7, but when we go back, we have a sample stored for the central lab testing at month 6, 3, 1, and 0, or forward at 3-month intervals. So you can see there's a time sampling time factor that Deborah had to work into the overall model. So here's what we might see. This is the site in the bottom, testing monthly with the rapid test, and then they get a reactivity on one of the 2 rapid tests. They confirm it with a 3rd or 4th generation assay, depending on the site, and these individuals remain seroreactive after that point in time. So we would confirm that the samples available for us then were at this visit, the one before, at here month 6, month 3, 1, and 0. So you can see we get big gaps in here of roughly 3 months between available samples. So we would go back until we had the first negative sample, RNA negative, and then forward till they reach stage 6. And that's sort of the gist of the data. And when we look at staging then, we would have found that this person was stage 5 here, and then stage 4, this is just theoretical, stage 4, stage 1. But we don't know when they developed 2 or 3 because we don't have any samples in there, right? So we got this 3-month gap, and you can see the issues around that. And then we would carry forward to the next sample near stage 6. So there's some imprecision in exactly defining when they move from one stage to another, but with a large enough sample size, you're going to pick up many of those step progressions depending on how close the site picked up a seroconversion relative to when the next sample was available. Optimally, when seroconversion was picked up at the time you're storing a sample, that's the best, but not always the case. So I've just abbreviated Deborah's modeling in simple terms, but she used a parametric model to test the time to each ephebic stage and to see if it was attenuated by PrEP. infection was assumed to be infection time was uniform over the model to be uniform over the infection interval, and the waiting time for infection to move from one stage to another was considered to be an exponential function. And every rate event for placebo, we were comparing the event rates for placebo and event rates of moving from one stage to another versus the effect of PrEP, and that's what the model was based on. She used the maximum likelihood estimation, and bootstrap permutation tests were used to develop p-values. So that's how this was all put together without any equations, except for some symbols, okay? So there was a comparison of viral load, which is RNA. When I refer to viral load, I'm referring to plasma viral RNA. There are other measures of viral nucleic acid, but this is what we were using. We used the architect signal defined as the signal cutoff ratio, which again is a several log, 3 log dynamic range for estimating the strength of the antigen antibody response between the groups. And this was done because of repeat measures over time in each individual. She used a general estimating equation model. The analysis of time to phoebic stage excluded seroconverters with sample gaps of more than 100 days. I mean, our samples are collected every 3 months, so if people missed their 3-month visits, then we excluded them because that wouldn't allow us to estimate the phoebic stages. Since the probability of detecting early phoebic stages is higher with shorter sampling intervals, the sampling interval was incorporated into this model of estimates to fine-tune it. So 2 definitions. PrEP is randomized to either placebo or to the PrEP arm, and then a sub-analysis was done on PrEP as treated, and that was defined as from the multiple samples that individuals had provided, any detectable tenofovir greater than 0.4 nanograms per mil, it was compatible with them taking, around that time, at least a tenofovir every 24 hours like they're supposed to. But it's clear that over the course of time, some samples could be negative for tenofovir or have lower levels depending on adherence, right? That's just the nature of this type of a study. So what are the results? All right, here's the 2 groups, 67 in the PrEP, randomized to PrEP, and 71 to placebo. The sex was similar between the 2 groups. Viral loads were similar between the 2 groups at baseline. Ages were similar. At randomized, obviously in going back, we found 14% of the PrEP group and 8% of the placebo group were actually infected at the time that they entered the study, right? We picked that up with RNA. That was missed, obviously, at the site, but we picked it up retrospectively. There were there were 9. Okay, so there were 9 subjects that were tested more than 100 days prior to the first HIV-infected visit in the PrEP group and none in the placebo group. And when we look at the time to detect seroconversion at the site versus what we detected when we went back retrospectively over all the samples, there was a significant difference between the PrEP group and the placebo group, in that more individuals in the PrEP group had a delay in the time to detection at the site versus what we were able to detect, right? Because we used more sensitive technology. The screening with the rapid test isn't as sensitive for picking up the early stages of HIV infection, and we did that retrospectively when we looked at RNA and used the 4th generation screen as a screening test rather than as a confirmation test. So let's look at the results by the specific aims. So the first specific aim was to assess whether the time to progress through the phoebic stages was affected by PrEP. And these are all of the individuals that were included for analysis. There were 113. And the dotted line represents the time from the first negative through to the first positive. at which time they were phoebic staged, and then the solid line represents the time from their first stage identification throug't to stage 6. So, for example, these individuals here, they're stage 2s. Well, let's look at this overall. Overall, you can see most people are picked up by 3 months, okay, which represents the vast majority of the data. And that's important because in our prep programs here, we screen every 3 months, right? We have people come back every 3 months and get retested. So we didn't see delays that put people beyond that, right? The second thing is there's a lot of variability in the pattern between individuals. The vast majority of these subjects were actually at stage 6 on their first 5 or 6 on their first at the first time they were identified. All right. Again, attesting to how rapidly the phoebic staging occurs over that 3-month period of time. And there were a few picked up as stage 1, but some stage 2s, a few stage 3s, but the vast majority were 4, 5s, or 6s. And then the progression after that point. So that's the data set that Deborah worked with to come up with these estimates with the provisos that I've already indicated. Okay? So if we look at time to phoebic stage then, let's just look at the raw numbers first. This is the as randomized group and the as treated group. And you see a consistent pattern between PrEP and placebo. And that is that there seems to be take longer to get to a stage for the PrEP group than the placebo group. It's sort of consistent, very consistent across stage and by group. The relative rates here are also very consistent, although they don't all reach statistical significance because of the power issue, not having enough subjects and a lot of variation in moving from one stage to another. In fact, as it turned out with the sample size that we had, reaching stage 6 was significantly delayed for PrEP at the 0.05 level. But the trend is the same for everything, and you can see that by the time, that was stage 5 rather, by stage 6 it was an 80-day estimate to the mean reaching of stage 6 for the PrEP group versus 49 days, 50 days for the placebo group. So it's a very consistent pattern limited by the power and the variation, biologic variation in reaching the stages. So it was reassuring to us to see such a consistent drop, and it was around 40% difference in time between the two. So there's clearly an effect. The thing is, obviously, is that clinically relevant or not. So let's look at assess whether the virologic or antibody responses were affected by PrEP. This is the viral plasma RNAs in all the samples. I think there were 235 samples, covering the placebo group in red, the PrEP group that didn't have tenofovir detected, and the PrEP as treated group on the right. And up in the top, I've summarized these to show that. I have an arrow. My arrow's not showing up in there. Okay. If you compare the upper as treated versus placebo, there was a significant change of roughly 6-fold. So the viral plasma level was decreased. When we look at the randomized, it was a 4-fold, and both of these were significantly different. So it's clear that PrEP does suppress viral RNA, okay, and it does it significantly, anywhere from 4 to 6-fold. Down in the bottom are a number of dots that indicate individuals that had no detectable RNA. And you also see that in the placebo group, and I'll say more about that in a minute. Okay. Again, we were getting some insight in the natural history of seroconversion here. And these data are summarized in this table for the 67 preppers and the 71 placebos. And we can see that 4 of 134 individuals, or 3%, had no RNA present in the plasma at the time they seroconverted, and 13 of 121, or 11% of the preppers, didn't have it. So it's quite possible that it suppresses RNA below our level of detection. That doesn't mean it goes away. It's just below our level of detection, which for our purposes was 40 copies per mil. But that raises some red flags, because and I'll editorialize right now, we don't know who's on PrEP or who's not on PrEP when in the lab when we do an assessment of HIV infection. And it's a cautionary note when we're screening people that they could technically have a negative RNA, and that doesn't mean they're not infected. But as I'll show you, the antibody response seems to be pretty uniform. All right, and we've actually run into this in one of our clinical trials where we clearly had antibody evidence of infection, but because there was no RNA detected, some people, not here at the University of Washington, but some people were reluctant to call the individual infected. Okay, and we don't know what they're on, but it's just something in the background that you got to think about. This is the antibody response. Antigen, early antibody, indeterminate Western blot with and without P31, so moving through the stages. And the antibody levels between placebo and the preppers were the same. Okay, so the strength, which we're able to pick up with the dynamic range on the architect, wasn't different, significantly different between the different groups, suggesting the overall antibody or immune response is pretty good. It may be delayed a bit, right? About a 40% delay in getting you from one stage to another, but you're going to pick up antibody if they're undergoing seroconversion. And remember, we always have the luxury of time. If your initial testing is negative and you believe the individuals had a true exposure, you can do subsequent follow-up testing, right? And nothing to stop you from doing that. The only caveat is that if you relied totally on RNA alone, you could be misled. 3% of the time in placebos and 11% of the time in people taking PrEP. So it's not insignificant. So the third objective was to assess an association with the delay in detection of seroconversion at the site using less sensitive screening technology versus what we did centrally. And here's the data for the time between the first HIV-infected sample tested positive at our lab and at the site. And we used 90 days as a cutoff. Again, I'm sorry there's no... Oh, there it is. Oh, it's back. Okay. And this shows us a couple of things. One is the vast majority of people, the difference between the site and us was usually under 100 days, 90 days. One difference occurred, a significant difference occurred in the PrEP as treated group. And one of the issues is if they're on suboptimal levels of tenofovir and breaking through, little black dots indicate individuals that were identified as having resistant virus to tenofovir. This is work done by Lisa Frankel in earlier parts of the study. But it really didn't, the resistance didn't result in a significant delay beyond the 90 days. And in fact, if we look at the delay between the site and us and use 90 days as the cutoff, remember we're sampling every 3 months, on the treated group was a significant difference. In other words, we were more sensitive than the sites. And that's not to be unexpected because the rapid tests don't have the same sensitivity as the platform liquid EIAs or CMIA assays. So again, that's something to consider. We're always dealing with cost, and it's obviously more cost effective to screen with rapid tests than it is with the larger platforms, but there's a cost to that, and that is that we are going to miss people, right? And this study showed that even with repeat testing by the rapid test at the site, those delays could be in this 3-month window, but very few beyond 3 months, okay? And that's encouraging because it says something about the frequency with which we do follow-up for people who are on PrEP and undergoing exposure. So in summary, PrEP during seroconversion slightly lowered progression through the phabic stages. It was a modest decrease in viral load of around 6-fold. And some participants had delayed seroconversion. The antibody response wasn't changed by PrEP, and regardless of PrEP, the rapid tests were not highly sensitive for detection of acute early infection. Again, that's to be expected. PrEP suppressed the viral replication during seroconversion by roughly 6-fold. The delay times were small, 1 to 4 weeks, and relative to the HIV testing intervals between 1 and 3 months, that's not so bad. And I think, again, the recommended follow-up period for serologic monitoring that we do every 3 months on PrEP I think we'll be fine. All seroconversions progressed through the full antibody response. We saw no skipping of markers. We saw a higher frequency of plasma RNA negativity in the PrEP group than in the placebo group, 10% versus 3%. This elongation of time to seroconversion could indicate obviously some alteration in the early immunologic response driven by lower viral RNA levels. The rapid tests are not highly sensitive, as I've mentioned, and 11% of the PrEP and 3% of placebo seroconverted without having detectable RNA. And I consider that one of the known unknowns. We know it's going to happen, but we don't know when someone comes to us for testing if they're on PrEP or not. Either the clinician may not know for sure, and we certainly have no way of knowing in the lab. So the higher frequency of visits with undetectable HIV RNA during seroconversion among those who were assigned to the PrEP arm suggests that the use of viral RNA as a confirmatory diagnostic marker by itself may not be sufficient. Reliance on seroconversion alone should be considered in the absence of RNA, as we've already found in one of our clinical trials. And again, a known unknown. Fortunately, what you have to do obviously is do multiple testing, but one of the tests that we have online to support our protocols is an assay that actually looks at cell-associated RNA and DNA in the cells, because it'll be a more sensitive marker if the plasma RNA is negative, if you have circulating cells that have virus in them, providing those cells are in communication with the plasma and whatever the reservoir is where the virus is located. But we specifically use that as part of our algorithm. It's not clinically used. We do it when people talk to us and try to sort out a difficult case, but it's something to keep in the back of your mind. Nevertheless, despite these limitations, which are not, I don't think, significant, there's a clear benefit to using prophylaxis, right, to prevent infection. And it's just that from a testing point of view, it may require multiple tests and it may require talking to the lab if you are surprised and get a negative RNA back, for example. But be reassured, there's no evidence that we're delaying the serologic seroconversion that we're so familiar with. There's a lot of people that think RNA is going to be the answer, right? It's more expensive than serology, and serology is cheaper and actually probably more sensitive when we start perturbing the normal seroconversion process by suppressing the virus. That it's not. I mean, that's a significant suppression of virus that clearly has an influence on the timing as you move through by about 40%. So these are all the players. It takes a village, a lot of people, and it's I think a very powerful study. It's shown so many other essential components of the PrEP use, and has had a major and significant impact on the implementation of PrEP worldwide. So, in summary then, we assessed whether time to progression through phoebic stages was affected or delayed by PrEP. The answer is yes. We assessed whether virologic or antibody responses were affected. Yes for virology, no for antibody. And we assessed the association of PrEP with a delay in detection of seroconversion. Yes, albeit modest, and not to a degree that would change our thoughts about 3-month monitoring on PrEP for seroconversion. So, this is the Grief and History statue. It's the Naval Memorial in front of Congress. And this was January 20th, 2017, and the Trump cavalcade is going towards the White House. I was very impressed by this when I saw it. New York Times. So last Saturday, who was marching last Saturday? Excellent. Who was in Washington last Saturday? All right. 92 days later, these are scientists marching down Pennsylvania towards Congress from the memorial. They came down Constitution and then down. And I had to get this picture of them marching towards me. Many went off to the left, which went along the base of Congress. People weren't allowed up on top with their placards. There was a police line just in front of me. And I had a harassing police officer saying I couldn't set a tripod up because it was some sort of hazard. Anyway, that's you guys. Some of you that are here were in there. And it was a very exciting time. However, there was also a march. At the march, there was a science poetry workshop. I don't know if did anyone go to it. It was a small little tent. Anyway, an entomologist presented a metaphor for survival of science in the time of Trump, and I'll let you read it. It's pretty to the point. Some of you may have seen it. It got quoted in the New York Times. The organizer of the march was a poet, actually, and she read one of her poems, and then there was reference to this. So I thought that was sort of cool. I saw some very happy people there, and a lot of young investigators. They outnumbered us, more stamina, but it was very encouraging, and it was a positive attitude, not a negative one. Like they really think they're going to make a change. Well, they are, right? And they were from all over the place, all over the country. So, and we were represented there in our own way. So it was very nice to be there and see this. The future, we will persevere, and if all comes to naught, we'll just taste terrible. Also, I just want to, for the laboratorians in the audience, this is Lab Professionals Week. I want to point out that there are over 300,000 professional laboratorians in the country, and they perform and interpret over 10 billion laboratory tests that affect our care of patients, and that's why we're here. That's why we do what we do, right? So I just want to acknowledge their important contribution to the work that we do both at research level and also at a clinical level. And if you haven't acknowledged it with your laboratorians that you work with, please give them chocolate. It does wonders, okay? All right, thank you very much.